Are you ready to elevate your expertise in the pediatric cardiology field? Welcome to the Pediatric Cardiology Fellowship, a premier one-year online program designed to equip you with advanced knowledge in the pediatric cardiology field. Our aim is to provide you with high-quality educational materials and up-to-date pediatric cardiology scientific knowledge delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is high quality, up-to-date, evidence-based, and well-structured. Why travel for training when you can learn from top pediatric cardiology experts online? Our program brings world-class instruction directly to you, no matter where you're located, through case-based discussions, Q&A sessions, virtual workshops, and personalized feedback. You'll receive high-quality education
that augment and complement your personal training,
all from the comfort of your home or workplace. Our pediatric cardiology program offers a comprehensive fellowship structured into 3 modules, 16 weeks each, with a total of 96 credit hours and in-depth training over 1-year period. Balancing work, life, and professional development can be challenging. Our Pediatric Cardiology Fellowship is designed with your busy schedule in mind. With self-paced learning modules and live virtual sessions, you can advance your skills without disrupting your clinical duties. This program allows you to learn and gain experience at your own pace. From mastering congenital and acquired heart diseases to specialized training in ECG, echocardiography, cardiac imaging, including MRI, diagnostic heart cath, electrophysiology and arrhythmia management, mechanical circulatory support, and cardiac critical care. You will develop the essential skills to manage children with various kinds of heart disease at any circumstances and healthcare setting. Upon completion, you'll earn an internationally recognized AACME accredited graduation certificate, helping you enhance your credentials, advance your career, and improve your patient outcomes. Join a growing community of pediatric cardiology professionals who have transformed their careers with this fellowship. Don't miss this opportunity. Take the first step towards mastering the pediatric cardiology specialty and transforming the way you deliver care to your sick children. Visit our program landing page and register to reserve your spot. Limited seats available. Don't miss your chance and register today.
To our Pediatric Cardiology Fellowship webinar. Today we have a very special webinar and also very special guests. As you know, that we are focusing today on pediatric arrhythmia from ECG to emergencies. We have 3 great speakers today, Dr. Volkan Tozko and Dr. Sanatani and Dr. Sanatani Shaw and Dr. Heba Al-Jibali. And we have also fantastic moderators, Dr. Simon Lee and Dr. Amira Hasmat. So here is our humble agenda today. We are going to start with the first speaker, Dr. Volkan, who's going to talk about approach to telemetry and EKG monitoring in pediatric ICU. Then Dr. Sanatani is going to talk about post-operative arrhythmia. Then we will have 10-minute case-based discussion by Dr. Heba Al-Jibali. So again, Dr. Volkan is a professor at the Division of Pediatric Cardiology and also is electrophysiologist at Istanbul Meatball University and also in Sidra, Qatar. And the second speaker is Dr. Sanatani Shu, who is a professor and section head of Heart Rhythm Service at British Columbia Children's Heart Center, Canada. Dr. Simon is our moderator. He's Associate Professor of Pediatrics at Northwestern University School of Medicine, Chicago, and Professor Amira Esmat is a Professor of Pediatric Cardiology at Cairo University. So we are starting our Pediatric Cardiology Fellowship, which is 1 year online fellowship. The date is Monday, May 4th. So only a couple weeks to go. If you haven't joined yet, and if you are interested, please do so. And please also take advantage on the 10% discount code, webinar 10, that is valid only for 48 hours. So please hurry up because the doors are closing in 48 hours. The application door will be closed. So if you haven't, please do. This is fantastic pediatric cardiology online fellowship program that is going to augment and complement your clinical training. It has every week new lectures recorded in a smart platform, case-based discussions, MCQs, journal club. So you'll be learning new topic, new subject every week. Again, you will have 24/7 access to a smart platform when you can do your tasks and assignments. Then by finishing this 1 year Pediatric Cardiology Fellowship, you're going to receive accredited certificate from the American Association of Continuing Medical Education. Just a couple of take-home messages here. The QA box, if you have any questions or inquiries, you can type it in the QA box. All of you should receive attendance certificate by next week. If you want not only to listen to the lecture, but also to see the spoken language at your earliest convenience, there is 140 language. You can activate the show caption you can enable it. Then you will be able to see whatever the lecture is saying. You can see it also in the screen. Again, all of these helpful tools, platform, educational activities has no values until you adopt this clinical knowledge and improve your standard of care and your clinical practice, because the great aim of education is not the knowledge, but the action. With that, I'm going to let Dr. Volkan to give the first talk of this session. And I'm very sure that you will all going to learn a lot today.
Hi, this is Volkan Tuzcu. I am the director of electrophysiology in Qatar at Sidra Medicine, and also professor affiliated with Istanbul Medipol University in Turkey. First of all, I'd like to thank WICCM for inviting me to be a board member recently, and also help organize this series of nicely organized teaching seminars. Today, I'll be talking about a practical approach to telemetry and EKG monitoring in ICU. And this will be mainly actually a practical overview of some interesting samples of telemetry recordings, and hope that will give you an idea about some basics with the intention of understanding the basic EKG principles in telemetry assessment in any ICU setting, and to be able to integrate rhythm findings with hemodynamic correlation. So here you see a typical telemetry setting where the patient also, as you see, has a CVP line, arterial line, and COT tracing, besides the pulse and of course the EKG. And you see all these numbers, and it's really important to be able to look at the relationships between these different parameters. So starting with a case where you see, if you look at the trend, which is very important to be able to look at the trend, as you see over several hours, it looks very strange. It's going up and down. There's sudden ups and downs, and one wonders whether there's any SVT, like the heart rate here is right maybe around 170 and actually goes up to 200. And And if you look at here, the heart rate is recorded as 200. But when you look at this rhythm strip, which is recorded at 25 speed, actually, if you notice this, there is the number of boxes is actually not looking like 200 beats per minute. It seems to be less. But if you look at the trend here, the heart rate trend, it shows you this very high rate. But if you look carefully, there's an N, which is means normal beat, and V is a PVC. But indeed, what you see, that's not a PVC, it's a T wave. So basically what you're seeing here is one of the common problems we see in telemetry monitoring. This specifically at that time actually giving you a large T wave, which is recorded as another QRS, and therefore it's like oversensing of the T wave as if there is another QRS, and of course it's overcounting. If you look further, the simultaneous pulse ox tracing, which is not always that nice, in this case very nice and clear pulse tracing, shows you much slower rate. And if you look at the pulse, here the rate is 108. So the patient's actual rate actually is 108, even on EKG, but even though the EKG tracing is quite clear, without much artifact, you end up thinking there's something going on when there's nothing going on. This is one of the common problems. You should always try to look at the pulse tracing also and make sure there's no overcounting. You see now I added the pulse recording here in blue. It's pretty stable rhythm, unlike the green ones, which is the EKG rhythm. Let's switch to the next example. We have here a normal looking rhythm with pulse ox and even arterial tracing. But then it seems like patients suddenly going into some maybe white QRS tachycardia. This is also another common scenario. Is it a real thing or not? If you look at the pulse tracing, there's no change at all. Even though I'm not able to see any EKG tracing here, one can easily say, indeed, there's nothing going on. There's nothing changing. Just looking at the pulse tracing, you can tell actually this was artifact, no matter how real or how suspicious it looks. So therefore, simultaneous tracings of hemodynamics is quite helpful in difficult assessments, especially artifacts. Here, another example, this patient seems to be having significant, fast heart rate beyond the limits, as you see, ups and downs and all these things. And actually, again, we have the same problem. First of all, the recording is showing very small QRSs. So whenever you have this T-wave oversensing or small QRSs, like in this case, always, again, pay attention to the pulse rate. Here, the pulse rate is much less. Even though heart rate seems to be fast, the pulse rate shows you much less. And here now I will add the pulse rate tracing, which is showing more normal rates for this patient when the EKG is showing lots of over sensing of the T waves. So therefore, this issue is quite important because we encounter this issue a lot. Here's another example. Looks like there's a triplet here, but the QRS is not looking very typical QRS. So one wonders, is there any, maybe this is an artifact or not? So sinus going in and again going on, and again you see the pulse here, and then suddenly we have this maybe triplet, but it really looks like not like a typical QRS. Little bit pulse, which is shouldn't be coincidence, so that's suspicious because you have a fast any type of arrhythmia, you can have a little bit pause after that, and it goes back to the same rhythm, but still it doesn't look like a typical QRS. I mean the waveforms. But then if you look at the pulse tracing here, and you will see that, and it will always come a little bit later after the the actual electrogram. You see this 3 beats back to each other at the same 4 actually, 4 of them at the same distances. It actually tells us that that was a real episode. So simultaneous assessments are very important. Again, another example. This patient seems to have sinus rhythm and suddenly 4 beats of maybe slow non-sustained VT. But indeed, if you look more carefully, even this QRS looks a little bit different. So it looks like this is fusion. So it's actually 5 beats. But is it real? I mean, we want to look at the pulse tracing, and we don't see much because, pulse not always that reliable pulse oximeter tracings, then of course you cannot compare. You cannot see what's going on. But again, this patient is having repeated episodes. Here is another one. Here is another one. But then again, the pulse tracing during those times, not reliable. And again, another time, this patient having the same QRSs, same type of QRS. And this time, see, you have nice tracing coming again a little bit later, same rate, and there's no artifact here. And so basically it reflects this real VT. So sometimes you need to look at different parts of the telemetry to be able to understand what you're seeing on the EKG is representing what you think. The pacemaker or pacing patient's assessment of telemetry recording is a quite deep area and requires a much longer presentation. And indeed, I will just show an example. What you see here is a A-sense V-pace. This patient most likely a post-op patient. But then we have these little pauses and this little pacing. Indeed, what's happening here, this patient is going in sinus, but then there's a PAC coming. You see there's the T waves on this patient when there's a normal pacing, but then this P comes early, so it's a PAC, and it actually is not tracked by the pacemaker, which is in dual chamber mode. This happens when you have the P wave falling in the P warp, what's called post-ventricular atrial refractory period. And it's a normal behavior. And since the system, the temporary pacing system in this case, not seeing the P wave, it is thinking there's no P wave. Actually, there is a P wave here, there's a P wave here. It's seeing this one, but not seeing that early one. And therefore, it's starting to pace here. That's why every time you have this little pause, you have a atrial pacing. So trying to do DDD behavior. Again, the pacing assessment can be quite complicated. And here again, we have a similar scenario. There is a relatively fast, tracking of the rate, and suddenly we have a P wave that is not recorded, and there may be few reasons for that. So another example, if you look at the trend, which is always very important to look at, this is a newborn with fetal ventricular tachycardia episodes on propionic flecainide. If you look at the rhythm, it looks quite irregular, but not irregularly irregular. It's actually regularly irregular. You see like 2 beats and then pause, 2 beats and a pause. If you look at the first of these beats, it shows like a P wave and then a narrow QRS. The second one is a little bit wider QRS. Again, sinus looking or maybe ectopic atrial rhythm. We cannot say by looking at single rhythm strip, of course. And then you see actually a wider QRS without a P wave. And actually this patient is having bigeminy, right? Ventricular bigeminy. And let's look at the actual pulse rate. If you look at the heart rate is 125, which is accurate because if you look at the normal beats and abnormal beats, you will see the 125 rate is reasonable. However, because of bigeminy, if you look at the pulse carefully, it's like half rates, 60s, 63 or so. And you can see in this example here, where the line is representing this actual strip here, the rate seems to be 125 or so, and it's a pretty clean rhythm strip for the EKG. There's no oversensing here. It's an accurate rate, EKG rate, but the pulse rate is less because you see the pulse waveform is actually different. Sometimes, you have the real EKG tracing, but it doesn't reflect the hemodynamics. So that's also important. Sometimes this happens when you have poor function. A patient may have, atrial bigeminy or ventricular bigeminy, and actually you may have single pulse actually with a normal and abnormal beat rather than 2 pulses. And effective heart rate in the patient hemodynamically actually may be half. So patient may be practically in very bradycardic state. So therefore, it is also important to, again, look at the simultaneous pulse tracings or, if available, arterial pulse tracing to understand whether the rhythm is reflecting and ending up in a normal hemodynamics or not. Another important area of telemetry assessment is really assessing what's going on. A lot of times, our ICU doctors obviously can be quite busy, and sometimes there is misinterpretation of events. For example, this patient, we were called because this patient had bradycardia and then, actually had to have a CPR after that. But when we look at it, actually, now you will see this line represents the, in time, and red is the arterial pressure, and then green is the actually rhythm. Here, the rhythm looks okay. The heart rate is 88. The pulse is actually following. Looks nice tracing. And if you look at the blood pressure, systolic arterial blood pressure is 91, so seems to be okay. Here's a flat line. So we know this is artifact of their closing the line, right? Because you continue to have the pulse and EKG. So therefore, this is only temporary. So we go to the next beat, the next page, and you see again this flat arterial line. That's because they're doing something, maybe calibrating, etc. Next page, in time, you look at the tracing where we show in this line. Now, arterial line comes back because they're opening it. Now we lose the pulse oximeter, but again, this time pulse oximeter is not reliable. So we can rely on the arterial pressure, which is around 95 or so. The rhythm is still the same, rate is still the same, 89. Okay, we go to the next page. And you see, again, everything looks pretty normal. There's not much change. The pulse pressure, though, a little bit lower, not too much, 87, but the rhythm is the same. Again, we go to the next page. Clearly, the pulse is less. You can say the blood pressure is dropping. And actually, it's 77. There's no change in the rhythm. You see that. Even the pulse oximeter showing shallow pulses. This continues to get worse. Now 71 systolic pressure, now 47 blood pressure with no change in the rhythm. Rhythm has been stable around 90 to 100, here 106. Definitely the issue here is not related to rhythm, without any question. We go to next page. So we were told bradycardia, right? The next page we go, and then it continues, and actually you end up in flat line. The patient loses the blood pressure. The rhythm still the same. So there is some significant hypotension, not related to arrhythmia, and that hypotension continues, and when that continues, you have ischemia, of course. There's no real circulation, and therefore, even though there's normal EKG, of course, the first thing, the QRS becomes wider because of ischemia, and when you continue, even wider QRS, after this point, you can have anything, and the patient ends up in bradycardia. You see this artifact which showing they start, CPR, and then, as you see in this example, it was a reflection of actually hypotension, but not through arrhythmia. So therefore, one of the really benefits of telemetry is assessing things in time and to be able to go back and look and document. A lot of the systems do not let you record more than 24 hours, so you have to be careful and record these things timely manner because it will be important if there's an issue like this patient for M&Ms or discussions, etc., documentation. You need to document these things, in a reliable way in case it needs to be reviewed later, because most of the places these telemetry recordings are actually not going more than 24 hours, retrospectively, and it's not also recorded more than that. So here is another example. The rate doesn't seem to be too much different, a little bit faster here, but the QRS is quite different. Look at this one versus after the middle one. And actually, if you look at this here, there's a little bit very short episodes of episode of tachycardia, but the QRS is totally different. It says normal means like normal QRS. This is normal. It's not possible, right? I mean, this is, okay, looking narrow. This is also looking narrow, but it cannot be possible. It's not possible, actually, to have both narrow QRSs with totally different, without any lead change, different looking. So one has to be different. One has to be a little bit wider. Most likely, this is a fascicular VT, and then patient goes into, looks like second part, PQRS, narrow QRS, and this is more like sinus rhythm. The fast one, most likely fascicular VT, okay? There could be other possibilities, but you need to have 12-lead ECG to be able to say better. So another thing, of course, especially in post-op patients, we may have atrial wires if it's post-op cardiac patient. If not, if you want to get, if you want to see the P waves better in an EKG like this, we don't see where the P waves are. It's a rhythm. You see, it's not looking wide, but there are some really narrow beats and a little bit wider beats. And we are trying to see where the P wave is. We are looking on the T waves. We are not able to see them. So we're wondering where the P wave is, what's going on. Yes, you can give adenosine, but it doesn't always help that much. Like in this patient, placing, getting an atrial lead because patient had an atrial wire. If not, we could have placed an esophagus lead, which would record left atrium. The spikes here, the sharp spikes, as you will see now, actually indicating the yellow ones, as you see. So the bigger one is the QRS, and then small spike, sharp spike, high frequency spike is the atrium. It's coming after the QRS and actually not related to QRS. And this one actually, green one, ending up with a narrower QRS after it actually, right after that, which is like, but again, it is dissociated from this previous one. Since you have a narrower QRS, these are wide QRSs, even though they're not looking that wide. So this is some sort of VT with not that wide QRS and most likely some fascicular type VT. And these are sinus capture beats that we see in sinus. And then you see the spikes. So therefore, esophagus or atrial ECG in this case can be very helpful. Another example, this is also very common when the patients are having tachycardia. We are also frequently called and see what is going on. Cannot see the T waves. If you do atrial or esophagus ECG, like in this case, most likely the right atrial lead was attached to the EKG, 12-lead EKG, and these spikes are showing at the end of the T wave, there's a P wave. So that looks like sinus tachycardia. And if you see heart rate variability also on trend, which is very important to assess in all patients, it will show that it was actually sinus tachycardia. The significance of trend. Trend is very important. Like 100 in a let's say this is a 7-year-old child is very normal, right? 100. But look at this trend. You don't need to see the patient. You don't need to see the EKG. And you see this is not normal. Either this patient is being paced or this patient is in an arrhythmia. Another day, this patient, you see going into double rate, 200. This is about 110, this is about 120. Even without getting an EKG, I can tell this patient is an SVT, some reentrant type of SVT, like a flutter type. We call it intra-atrial reentry tachycardia. It's 220 beats per minute in the atrium, and actually 110 beats per minute in the ventricle. So here 1-to-1 conduction, here 2-to-1 conduction. I can tell these things even without looking any EKG. But this is left side. This patient, when it's really 220 beats, of course you give adenosine and you see this flutter-like atrial waveforms. You can also see these things in trend. When there's changes slowing, like in this patient, very abnormal trend, the fast rate. But if you look at the slow areas in the telemetry, you will see like extra P waves, which will give you the diagnosis even without giving adenosine if there is slowing areas. So we will be finalizing with this few examples. Like this is a patient with LV non-compaction. We are called to assess this patient because of having sinus tachycardia. So heart rate 190 to 200, and the rate suddenly increased actually. So when you look at this, what you see is 190 beats per minute, okay? But we have no idea. We cannot say of course, with one rhythm strip. When you continue actually, to next slide, we have to look at the trend. Like this is showing 24 hours. When I was called and I was told sudden increase, I want to see the 24 hours, what was going on. Do you see anything sudden here? We don't, right? So therefore, it was a misconception. There was no sudden increase. But this is 24 hours since we were called just maybe recently. So we need to look at the shorter time periods, This is 4 hours, last 4 hours before we are called. Again, I don't see any sudden change. It gradually went up to 190, okay? This is last 2 hours. Again, definitely there's nothing sudden. Let's look at the rhythm. I mean, actual strips. So we zoom on the strips, and then you will see that we have difficulty seeing the P wave. But indeed, P wave is on top of T wave. If you do ECG on this patient, you will see that actually it is sinus tachycardia, and the trend is helping us a lot, even though you're not able to see the P wave. If you go backward and look at the slow areas, you will be able to separate the P. And this patient had like borderline first degree AV block. When you have that, if you think about first degree AV block and sinus tachycardia, your P wave will end up on T wave, and you may not be able to see the T wave. And then what you need to do, sometimes you may need to give adenosine to slow the rhythm down a little bit to see by doing EKG at the same time. And sometimes just looking at the slower areas of the rhythm, going on the telemetry, wherever it's slower, and be able to differentiate, dissociate the T and the P waves. So you can see when the rhythm is slower, the P is coming after the T or towards the end of the T. You'll be able to understand, and with the gradual change to a faster rate, you will see the gradual change, and you will be able to say, no, this is not some other arrhythmia, it's only sinus tachycardia. So I'm ending with just announcing you that I've been doing many years, for several years now, almost weekly, as much as possible weekly, half an hour pediatric EKG arrhythmia seminars, and I'm reviewing like different patient scenarios, mostly for ICU setting, ED setting, etc. It's Tuesdays, Turkey or Qatar time, 12:15 in the afternoon to 12:45 for half an hour. If you want to join, just get this QR code, and this is our WhatsApp group for pediatric EP seminars. International, many people join, and seems like helping a lot. So I'm ending here, and hope I gave a little bit of synopsis of the important elements, at least some of it in this short talk.
Thank you, Dr. Volkan, for this highly illustrative lecture that highlighted the importance of the telemetry. Good afternoon, everybody. It's my pleasure to share up this WICCM continuous educative webinars. And this is the second one, is regarding cardiac ECG and cardiac arrhythmia. Now it's another pleasure to introduce our professor of pediatrics, Shubhan Sanatani, who is a distinguished pediatric cardiac electrophysiologist in University of British Columbia. For a long time, he has a leadership in treatment of complex heart rhythm and disorders and research in sudden death. Now it's time for him to start his lecture on an introduction to post-operative arrhythmia.
I'm Sanatani, and I'm a pediatric cardiologist and electrophysiologist from Vancouver, Canada. I'm delighted to have joined the board of WICCEM recently to support the new Pediatric Cardiology Fellowship Program. Today I'm going to be talking to you about post-operative arrhythmias in the ICU. The talk is entitled An Introduction because this is really quite a big topic, but I hope to impart some of the key practical principles that will be important for you to know. So today we'll introduce some general concepts. We'll talk about some of the management strategies and also talk about cardioversion and adenosine, which are both common topics that come up when faced with a child who has a postoperative arrhythmia. So some general practical points. We often get asked as cardiologists and electrophysiologists to make decisions based on a limited strip, a telemetry strip, or 2 leads. And using a single lead can make things harder than it needs to be. So here you see this lead, V6, shows a normal complex tachycardia. Rate is about 280 beats per minute, but no obvious P waves in the lead you've selected. However, in the other leads, lead 3, lead V1, there's quite a clear P wave. And here you can see the QRS and the P wave. You can even measure the RP interval, the time from the QRS to the P wave, which can be helpful sometimes in differentiating tachycardia mechanisms. So in general, from an electrophysiology perspective, we always want you to try and get a 12 lead and get a much better look at the details. Now, when the alarm starts sounding in an ICU, people get worried and they want to act quickly. However, if the patient's brain is working, you have time to use yours. So this might mean taking some time, getting that 12 lead, getting your calipers, even sometimes calling for help or sending a tracing to someone. So, and the baby may be irritable because that would be a very appropriate response to an arrhythmia for most of us. So what are the post-operative arrhythmias that we see in the ICU? So this book by Daniel Kahneman, which inspired a Nobel Prize, is really thinking fast and slow, talking about something quite different. You can see here an illusion where these three men are actually all the same size, but the lines make them look different. So we're thinking fast and slow. So here, of course, in the ICU, the alarms are going to sound for bradycardia because the R to R interval is quite long. But when you take a closer look, you can see that there's actually a P wave in the ST segment that has not been conducted as it's come during the refractory period. And so these are actually extra systoles that are making the rhythm slow. So the treatment is not necessarily aimed at bradycardia, but in fact at the extra systoles. So what are some of the arrhythmias we see? We see slow rhythms, which are essentially sinus bradycardia, non-conducted ectopy as we just saw, and complete AV block. The fast rhythms, the most common one is sinus tachycardia, which we've not shown here, junctional tachycardia, which we'll be talking about in more detail, and then some of the atrial arrhythmias. And it's quite uncommon to see ventricular tachycardia in the post-operative setting. So here is a slide showing a very slow ventricular rate. The ventricular rate is approximately 50, and you can see the P waves are marching through quite independent of the QRS, and there is no variation of the R to R intervals. P waves that should conduct do not. So here you see a P wave that is nowhere near the T wave, and so the myocardium should be able to receive that. But here's a different type of tracing. In the middle is a section clearly of sinus rhythm with P waves conducting. There's a one-to-one relationship. In these slower segments, particularly at the beginning of the tracing, the PR interval gets quite blurred, and in fact, the P waves and the QRS are occurring at almost the same time. This is a sinus bradycardia with a junctional escape rhythm. So the AV node has taken over. The reason I show you this is really to talk about a term that is often not fully understood. That tracing demonstrated AV dissociation. Both tracings demonstrated AV dissociation. The atria and the ventricles are activated independently. The atria by one pacemaker, usually the sinus node, the ventricles by another. AV dissociation is a much broader category than complete AV block. Of course, in complete AV block, there will be AV dissociation, but the converse is not always true. So let's talk briefly about postoperative AV block. It occurs in about 5% of patients, of whom about 20% will require pacemakers. So about 1% of congenital heart surgery carries a risk of a pacemaker, usually in operations near the AV node, ventricular septal defect in particular. Conduction usually recovers within the first 10 days, and that's been shown in a number of studies. When we look at variables that may improve recovery, there are not really any interventions. Typically, one has to wait. Steroids and isoproterenol were not associated with a lower likelihood of a pacemaker. I know many institutions will give steroids. So far, that has not proven to reduce the risk of a pacemaker. Let's change our focus now to the fast rhythms, which are, of course, much more common. So this is a typical tracing. This is a 3-month-old, and you get called to the bedside. This is post-VSD repair earlier in the same day. And what you can tell from this tracing is that it is not easy to see if there are clearly P waves in front of each QRS. So what can you do to get more information? Most of the patients who are in an ICU after an operation will have pacing wires, and ideally you'll have both atrial and ventricular pacing wires shown in the cartoon illustration here. Our particular ECG machine is set up so that one can get the wire study recorded with V2, but each ECG machine may be configured differently how it displays the precordial leads. So we want to run paper with both the wires, but also leads without wires, because it's difficult to interpret the tracing if all the tracings have wires. So here you can see the top tracing is a wire study, and you can see there are 2 types of spikes. So there are these large spikes that don't exactly align with the QRSs. The QRSs align, in fact, with the smaller spikes, which makes sense. This is an atrial wire study. So you've connected directly to the atrial temporary pacing wires. And you can see the P waves are very regular, but they are not affected and they are not aligned with the QRS. So this is VA dissociation, meaning the ventricle is activated by a focus that is not influenced by the atrial. And likely the atrial rhythm is a sinus tachycardia. The rate is about 150 beats per minute. And that would be quite typical for a post-op VSD. So this is junctional tachycardia. Now, the VA relationship is not always dissociated. Here is a quick illustration of the VA intervals that change. And this pattern we are quite familiar with. The VA interval starts and it prolongs gradually, and then one is not conducted. So this is wanky back, but in the opposite direction that we're used to seeing it. So we can have VA wanky back just the same way we can have AV wanky back. So one can have a VA conduction. A quick few points about junctional ectopic tachycardia. Typically it's post-operative, but there are some cases of congenital junctional tachycardia, and I'll show you one shortly. The mechanism is not known. We know some risk factors, certainly an operation in the area, and the catecholamines. People used to say that it had a lot to do with the surgical technique, as well as the use of inotropes. Operations, in particular ventricular septal defects or tetralogy operations, where there's a lot of manipulation of that area, are most commonly associated. But one can also see it even after transposition or aortic work. Less common to see it primarily after a Fontan. In a Fontan, it's more likely that there is sinus node dysfunction, and therefore the AV node will take over. So-called jet junctional ectopic tachycardia is usually in the first days of surgery and usually self-resolves. Does not respond to cardioversion. Adenosine may have some effect, but not usually much effect. It may change the VA conduction, so you may have transient dissociation. And certainly in the era when we had a lot of junctional tachycardia, it was associated with a lot of mortality, but we have gotten better at treating it and recognizing it. So as we've talked about, the QRS morphology really needs to be the same as a conducted beat. Now, you don't always have the luxury of seeing that, especially if the child has come out already in the arrhythmia. If the child comes to you in sinus rhythm, it's important to get that ECG fairly early so you have that for comparison later. As I mentioned, the relationship between the ventricle and the atrium is quite variable. You can even have one-to-one conduction. Now, one of the most challenging things is to determine if it truly is a junctional rhythm, especially when you have one-to-one VA relationships. And sinus tachycardia can look like junctional tachycardia, especially if there is a long PR interval, which you may see after cardiac surgery. And so doing the wire study and also observing the behavior of the rate over time can be important. Of course, atrial ectopic tachycardia and ventricular tachycardia need to be considered, especially if there is a wide QRS. I've mentioned already some of the risk factors: the young age, the longer operation, and inotropes, as well as cardioprotection. The first step really is to make the correct diagnosis, and one wants to ensure that there is not some intrinsic patient factor that is driving the arrhythmia, particularly if there has been a challenging operation in around the ventricular septum. The goal usually is to slow the ventricular rate so that one can pace atrially. AV conduction may not always be intact, so you may have to have dual chamber pacing. To lower the rate, sometimes it can be helpful to reduce the inotropes, which is sometimes counterintuitive, but reducing the inotropes sometimes gives you a better ability to restore AV synchrony. We still use cooling, which is a fairly old technique, but sometimes is very necessary. Certainly we aim for normothermia and treat fevers aggressively. In the current era, one of the most important medications is not actually listed here, and that's dexmedetomidine. We don't usually use digoxin or propafenone anymore. There are institutions that are very loyal to amiodarone, whereas others are loyal to procainamide. In the current era, it's still largely up to different institutions. When using amiodarone and procainamide, we really are cautious about the negative inotropy, and we want to have the surgeons definitely aware when we're going to start this negative inotrope in a post-operative patient. And sometimes the junctional tachycardia doesn't need treatment at all. So if it's hemodynamically well tolerated and not particularly fast, sometimes simple observation is okay. So this is a 5-week-old who had a collapse at home previously well. And I find this tracing quite interesting. This is a narrow complex tachycardia. And one always learns most from transitions. So one can see here there are some changes. So there is a QRS followed by this very negative deflection, which we assume must be a P wave. And here the P wave is missing and then it returns. And so the fact that the tachycardia continued on at the same rate where the P wave changed tells you that the atrium is not determining the tachycardia. If one simply looked at the other part, one may say this could be just a reentrant SVT with VA conduction, or one could even say atrial tachycardia with a long PR. However, the fact that the tachycardia continues where the VA relationship changes means that the atrium is not a necessary part of the circuit. That allows you to make the diagnosis of congenital junctional ectopic tachycardia, which is a very rare arrhythmia, but it has allowed us to learn some treatments which are very effective also in post-operative junctional tachycardia. So people have used ivabradine, which is a selective HCN blocker, a so-called funny channel, which is the main determinant of the sinus node rate of firing. And people have been using this now for about 10 years to slow sinus tachycardia, atrial tachycardia, and junctional tachycardia. And here is a study comparing ivabradine to amiodarone, and this was a open label non-inferiority study which did in fact show that the ivabradine was not inferior. And we have started using ivabradine in our unit. It is orally administered. However, the absorption seems to be satisfactory, and we've seen some good results. And other centers have also gone to this as a first-line agent. So I think we'll see more and more use of ivabradine in ICUs around the world. We're just going to switch our focus now from junctional tachycardia and look at this strip here. Here is the strip with a lot of atrial activity compared to QRS. So when the atrial rate exceeds the ventricular rate, we think, of course, of an atrial tachycardia with variable AV conduction. So here we see 3 P waves between the QRS. Mostly we have 2 P waves between the QRSs, or 2 to 1 block. Here we have 3 to 1 block. The atrial rate is quite regular, and so this may be a form of flutter, or it may be an atrial tachycardia. And I don't think one can differentiate that. Again, back to my earlier point, don't try and make difficult decisions using just one lead. So one would definitely get a 12 lead and look for typical flutter waves. This was called atrial flutter, but again, one cannot tell from this tracing whether it is atrial tachycardia or not. And there you see the atrial rate. So would one use cardioversion in this? Certainly one could try. It would likely be effective if this was a reentrant mechanism, atrial flutter, for example, but if it's an automatic tachycardia, cardioversion doesn't tend to work. I include this picture here from 1792. This is an early machine used to cardiovert with energy stored in what was called a Leyden jar, and the technology, of course, has evolved greatly. It's quite an interesting history to read the history of defibrillation and cardioversion. There are some rhythms, of course, that don't respond and don't prompt even on an AED to have a shock. Those are pulseless electrical activity and asystole. And unlikely to respond are automatic tachycardias, like junctional tachycardia, sinus tachycardia, atrial tachycardia. But one doesn't always know if they are going to respond or not. Thus the importance of getting the 12 lead, taking time, potentially sending the tracing. Now, in general, the teaching is if there is significant hemodynamic collapse or compromise, then one would proceed with a shock regardless. Pad position sometimes has to be in an anterior posterior if it is a small child, because there isn't enough room on the front of the chest. And one has to remember that cardioversion is temporary, so it doesn't affect a long-term change that's going to prevent the rhythm from recurring. So one might use cardioversion acutely, but one has to have a medical plan or an antiarrhythmic plan, or remove some of the other risk factors, such as severe electrolyte derangement or a very long QT interval, for example, that need addressing. Along with cardioversion, I'll just mention briefly the concept of overdrive pacing, which is also available in the post-operative patient, especially the one that has wires, atrial wires or ventricular wires shown here. And this is very effective if the chamber being paced is part of the circuit. So you can see that in this typical AV reentrant tachycardia, the atrium is part of it, so you might be able to terminate it both with atrial pacing or ventricular pacing. Now in junctional tachycardia, like we saw earlier, the atrium is not part of the circuit, so you wouldn't terminate it with atrial pacing. You can pace the atrium without terminating the junctional tachycardia. This is a slide from some work that we published with my colleague and our fellow at the time. And essentially, we hear a lot in the cardiology world and in the electrophysiology business that adenosine was given with no effect. However, the most important thing to do is to make sure that one runs paper while the adenosine effect is happening, because we can usually see something. There can be a brief change of the VA conduction. There might be a transient slowing. There could even be AV block with persistence of the atrial tachycardia. So the responses to adenosine actually give a lot of diagnostic information, and rarely is there truly zero response. So always run paper and give the adenosine in a good dose. In the last couple of minutes, I'm just going to introduce an important concept, and that is the long RP tachycardia. So here you see on the telemetry, there's a sinus beat, there are 3 sinus beats, and then the P wave changes in appearance, and the P wave is negative. Now, one doesn't know from this tracing whether this is an atrial tachycardia or what's called PJRT, a slow retrograde accessory pathway. However, in general, long RP tachycardias can be incessant, and so they are often associated with significant cardiac dysfunction. And so always be careful when treating a long RP tachycardia, because here is an echocardiogram and you can see a very dilated and globular left ventricle that is barely contracting. So the long RP tachycardias are often the cause. I just want to thank my research team and my collaborators for all the work that we do together. I really want to thank the WICCEM for having me join. It's truly exciting to be part of this. I will look forward to being at this lecture and learning together with you.
Thank you, Dr. Shaw, for sharing us your expertise in such a field. We all liked this great talk. And now it's time to shift to our Professor Dr. Heba Al-Gebali, who is one of the pillars of the WICCEM intensivist fellowship, and also one of the pillars of our cardiac surgical ICU. She will give us the talk about some of the clinical case scenarios that we might met in our cardiac surgical ICU.
Good afternoon. Here is a case scenario about a pediatric post-operative arrhythmia. Here we have a 7-month-old baby, his weight 6 kilograms, admitted to the CCU after successful repair of ventricular septal defect 6 hours ago. He had a stable initial post-operative course. There was sinus rhythm, heart rate 140 to 150 beats per minute, blood pressure 85/45. 30 minutes ago, the nurse alarmed you that the monitor is showing a sudden rise in the heart rate of 175 beats per minute with subsequent drop in the blood pressure to 58/32, indicating hemodynamic instability. Immediately, a 12-lead ECG demonstrated the AV dissociation and the rhythm appeared irregular. This is the surface ECG. We have a lead 2 rhythm strip, that of that infant, with showing the post-operative jet. We have the atrial activity or the B wave marked in blue lines, while the QRSs are marked in red. We can see that the QRS complexes are narrow, and we can note also the dissociation between the atrial and ventricular activity. We have a chaotic distribution of the atrial activity. Sometimes, as shown in the blue lines, it comes before the QRS, sometimes after the QRS, denoting the AV dissociation. This is because that the origin at the AV junction, possibly due to AV nodal injury. The decision was to cool the infant to 35 degrees centigrade and give him a loading dose of amiodarone. That was successful in lowering the heart rate. That means we got a rate control, but the baby was still junctional in jet. That might indicate some form of AV nodal injury. Then the decision was to do consecutive atrial and ventricular pacing, ensuring a good AV delay in the programming. Now the rhythm strip show consistent atrial capture, and the ventricular rate and ventricular rhythm or the QRSs immediately follows the based atrial rate. That was successful in regaining hemodynamic instability of hemodynamics and improving hemodynamics, and the blood pressure improved to 78/42 mm². Here we have a question to the audience, and we'll both the slides. to have the answer in our chat box. Which of the following best explain the physiologic rationale for successfully using the atrial overdrive basing to treat JUT in this scenario? A. Overdrive basing directly suppresses the junctional focus by depolarizing it at a higher rate. Overdrive suppression. B. Overdrive basing induce re-entry that terminate JUT focus. C. Overdrive basing capture the atria and the ventricles simultaneously, creating a refractory period that blocks JUT. D. Overdrive basing lowers the core temperature, which shows the junctional automaticity. Here is our second question. While initiating the overdrive basing for JUT, which of the following is the most critical safety measure to verify? A. Ensure the basing output is at least 20 milliampere to guarantee ventricular capture. B. Confirm consistent atrial capture on the ECG. Basing spike followed by a B wave, then a QRS. Set the basing rate to exactly match the underlying JUT rate. Discontinue all antiarrhythmic medication before starting basing. I will give you some time to answer in the chat box. Okay, let's have our answers for question 1. What is the physiologic rationale behind using the overdrive basing? Correct answer was A. Our explanation that the principle behind this technique is based on the concept that basing the atrium at a higher rate, the abnormal electrical activity causing the arrhythmia can be suppressed or converted to a normal sinus rhythm. Let's go to the technique of the overdrive basing and some of the troubleshoot we may face. And the correct answer was B. The primary goal is the atrial capture. To visualize the atrial capture on your monitor on ECG, you must see the basing spike followed by a B wave and confirm the atrial depolarization, then see the QRS following the B wave. If you fail to capture the atria or simulate the atria, you are not overdrive basing the junctional focus. Ventricular capture in A without capture is dangerous as it could induce VF. Rate should be 10 to 20% above the junctional ectopic rate, not equal to. Antiarrhythmic are typically continued and you cannot stop the antiarrhythmic during the overdrive basing. Here we have this ECG showing effective overdrive basing, where you can see the atrial spikes followed by the atrial capture and followed by the QRS, hoping this atrial stimulation or atrial overdrive basing can overcome the diseased AV node. Here is some of the challenges that can arise during the atrial overdrive basing, and one of the important things is to understand the pacemaker that you are using. Number 1, if the basing is not synchronized with the patient intrinsic rhythm. Number 2, sometimes when we are lowering the sensitivity of the atrial basing, we can go into basing induced arrhythmia. One of my patients have went into AF to low sensitivity of the atrial programming, patient discomfort or palpitation associated with basing. These issues is very important to address and to understand how to program my pacemaker to be safe for the patient. Take-home message. Junctional ectopic tachycardia is common after surgery of the heart involving areas close to the AV node, like those involving the VSD closure or TOF with associated patch closure of the VSD. First-line management is cooling, amiodarone, prokinamide, or IV sotalol, and optimize the electrolyte, particularly potassium and magnesium. Overdrive basing is a powerful tool when medical therapy does not help me in achieving the hemodynamic stability, which is my ultimate goal, and to optimize the patient cardiac output and prevent the fatal outcome of uncontrolled arrhythmia that may progress into low cardiac output state with poor prognosis. Here we have a basing algorithm. It summarizes all what we have discussed prior, that when we have medical therapy that fail to achieve hemodynamic stability, we may consider the atrial overdrive basing, and we have to take care about achieving a proper atrial capture and ensure adequate AV synchrony and programming well for the AV delay. And also we have to remember that we have wean off the pacing gradually and monitor the recurrence of jet. Here let's check our second baby, 4-month-old, 5.2 kilo, VSD closure, left to right shunt. She had elective VSD batch closure via median sternotomy, cardiopulmonary bypass with cross clamp time 52 minutes. Here the VSD was located to close to the non-coronary cusp of the aortic valve. The surgeon places a dacron patch, temporary epicardial pacing wire, atrium ventricular are placed as routine. The chest was closed and the infant was transferred to the CCU. Just prior to transfer to the ICU, the infant became suddenly bradycardic, heart rate 55, atrial rate 130, and we have this rhythm, this ECG showing a clear AV dissociation where the atrial rate is different than the ventricular rate with bradycardia. Which of the following is the most appropriate immediate intervention? A. Administer IV atropine, start isobutanol infusion, connect the temporary epicardial pacing wires and base at 150. Let's remember that the surgeon inserted atrial and ventricular wire, gave a fluid bolus of 20 ml per kg, perform bedside echo before any intervention. Our correct answer is C. We have an infant with complete heart block causing hemodynamic compromise. We have to immediately connect the epicardial pacing wires into the pacemaker and start VVI pacing to restore the cardiac output. Atropine is ineffective for infranodal or avinodal block that's complete and not due to high vagal tone. Isobutanol may increase escape rate but slower and less reliable than pacing. Fluid bolus doesn't treat bradycardia. Echo can be done for initiating pacing but should not delay life-saving intervention.
Thank you so much, Professor Heba, for this very nice case-based discussion. Now we have, I think, about 5 minutes for question and answer, and we'll let Professor Simon Lee to lead this session.
Thank you, Amar, and thank you to all of our speakers for really great lectures and cases. I mean, some of these strips, I mean, I feel like I was learning. I was trying to take some notes as well. So this is fantastic. So I think there are a couple of questions that came through. What I will do is, why don't I read some of them, even if they've been answered in the Q&A, and then if the speakers could elaborate a little. This first question will be for Dr. Volkan. This attendee was asking, the first example of atrial lead ECG be jet rather than VTAC, or is it Bell-Hassan type? How do you differentiate, I guess, between overall some of the wide complex arrhythmias versus narrow complex with aberrant conduction, I'm guessing is the question?
Yeah, that example was showing actually a relatively narrow looking QRS, but it was wider than the baseline QRS where we had sinus capture beats. The atrial actually wire was showing us that there is VA dissociation or AV dissociation, whichever way you want to look at it. And then clearly QRS was slightly wider. So it's not coming from his bundle. It's not coming from junction. It's not like a typical wide QRS. And it's not aberrancy, obviously. Aberrancy happens when you have a temporary wide QRS, and usually we see that with SVT, and that's certainly not a typical SVT. So that's why I called it most likely a fascicular type VT. Yeah.
Thank you so much. The next question is for Dr. Xu, which he has answered in the Q&A section, but if you could elaborate a little bit. Awad Bamakrama was asking about ivabradine in jet.
Yeah, I mean, it's relatively early days in terms of other centers using it, but certainly more and more centers have used it. I shared a publication showing non-inferiority with amiodarone. And I think because it is so difficult to study in a proper trial basis, people are just starting to adopt it. Certainly that's how we've been doing it. We've used it often in combination. So we are a procainamide center when it comes to that. So we'll potentially have a procainamide and then add the ivabradine, and it only takes 1 or 2 doses to start seeing an effect. And again, the goal is not necessarily to get rid of the jet, it's to get the jet at a rate that you can pace over. So if you have atrial pacing or dual chamber pacing, then you can you overcome the hemodynamic compromise.
And Dr. Volkan, do you use ivabradine for JET at your center, or what is, I guess, your center's experience with treating JET?
Yeah, in Turkey, our group uses in Qatar also we use it. We use actually still amiodarone. I use a lot, but in certain cases we prefer ivabradine. And I remember the first time I used it actually that it was reported for a few cases. This patient was hemodynamically in very bad stage and was not even a clear ECMO candidate. The surgeons, the CICU doctors were really using amio, etc. They didn't know what to do. So this was my first, and after the first dose, there was significant slowing. After second dose, there was no more jet. It was just amazing. Patient was having a lot of difficulty. So yes, we use, but as it was shown by Dr. Shu, shown that it affects a little bit later than amiodarone or procainamide. That's the only downside. So you have to wait longer time. So our still instinct is like to start something that will act quicker most of the time. And then if you have any difficulty, we can switch or add ivabradine. Yes, it can be very helpful.
All right. Thank you very much. Dr. Shu, I was hoping you could actually go through this question a little bit more. This question, will pacing be more than 175 beats per minute, that of jet rate? Can it affect cardiac output? And I guess just sort of the more basic or fundamental question of what is the advantage of overdrive pacing, even though it's a high heart rate? And I think maybe going into a little bit about the advantages of AV synchrony for the audience.
Yeah, sure. And I think in the healthy child, so if we just think about a child who doesn't have open heart surgery or congenital heart disease, I think AV synchrony is not as important. So most of us have followed kids who have congenital AV block, who are running around, who are active, who are not completely dependent on the atrial contribution to ventricular filling, and they are often asymptomatic. As one gets older and diastolic compliance reduces, that contribution of the atrial contraction is more important. However, in the post-op patient, or even in patients who have congenital heart disease, AV synchrony is much more important. And so junctional tachycardia, as we've seen nice tracings today from both of us, the AV synchrony is not there, so you lose on the cardiac output. So really, that's what you're focusing on. Now, as I put in the text, a heart rate of 175 may be exactly where this neonate who's maybe on inotrope, epinephrine, may be contributing. They may have a heart rate of 175 physiologically, but the difference between atrial pace 175 and a junctional tachycardia of 175 is that atrial kick, that extra filling. And most of us have seen it on the art line, where the art line is a much better waveform. As well, we shouldn't forget the other side, the venous pressure, the CVP, right? Because we have to get blood back into the heart. And if you have a very high CVP, you end up giving lots of volume and giving lots of fluid boluses to support preload of the RV. The lungs, of course, are also impacted by this. So having AV synchrony also usually has a lower CVP, improves your RV filling, better flow through the lungs.
Great. Thank you so much. And maybe we'll have this be our last question. It's kind of a big one, so I will open it up to either of you or both of you to answer. This question comes from Somia. She asked about the causes of WPW in pediatrics and the management. So feel free to try to keep this more of an overview because I know it's a big it's a big question.
Well, I'm gonna put in a plug for the WICCEM course. So the Pediatric Cardiology Fellowship, it's brand new, it's starting up. You have 2 electrophysiologists on the panel here today and very knowledgeable EP, Dr. Amira and Dr. Heba. And so we'll be doing a lot of teaching. WPW is not just a 1-hour lecture, it's probably a 2-hour lecture. You know, what causes it? What is it? Why do we worry? Is it associated with congenital heart disease? So lots of questions, but basically it's the most interesting of the accessory pathways, conducts from atrium to ventricle, is associated with some congenital heart disease. But I really think I invite our question asker to sign up for the fellowship. And we're going to talk about this and lots of other things over the year.
Very nice, very nice. I think that's a good end as we have good start. So I really thank all of our contributors today, our moderator, Professor Amira and Professor Simon, our great speaker, Professor Sanatani and Professor Vorkin and Professor Hibatullah Al-Jibali. And also I would like to thank our attendees. We have up to 600 attendees from 42 countries. And as Dr. Sanatani said, it's just we are scratching the surface today, but there will be a deep dive in the fellowship. We'll have every week in a smart platform with 24/7 access of all of our fellows. Very high quality material that was created by about 20 board member professors and expertise from all over the world. By tomorrow, all of you should get the link of the recording of this webinar, so we'll share it tomorrow. I saw some question about some interest in PDF of this lecture, so I will ask Professor Sanatani and Professor Volkin if they can share with us a PDF of their presentation. We'll also share it with the attendees. And by next week, all of the attendees should get certificate of attendance. Again, if you haven't joined our fellowship and if you are interested, please do. The door is closing within 48 hours. And with that, I really wish everyone good rest of his day, good afternoon, good evening, good night. Bye.
Thank you, everyone.
Thank you.